spine. Again, welcome everyone to our new session with the virtual spine. It'll be miscellaneous cases today. Some of our co-hosts and co-faculty are busy in the operating room, so myself and Dr. Rasuli and Dr. Galgano will show and discuss some cases, miscellaneous spine cases. So let's start. So I'm gonna share my screen here, and you guys see it? Okay, do you guys see everything that I'm displaying?
Yes, looks great.
Okay, beautiful. Okay, so let's start with this first case. It's a trauma case. A 37-year-old gentleman suffered a MVA. At the scene, he was reportedly weak in the upper and lower extremities, quadriparetic, and had some mild traumatic brain injury. And then on arrival, he was found to be quadriplegic. Obviously, they pursued the ABCs, and he was stabilized from that perspective. He had a mild DAI, diffuse axonal injury from a D perspective or cranial perspective. So, and that's the CAT scan that was obtained. It goes down to T1, but that's the area of interest. Do you see anything that stands out here? And here Alex has joined us as well with this lateral or sagittal CT. Well, it doesn't show much. Maybe the BDI is a little elevated, but not really. So we're looking here at the parasagittals. Do you see anything that stands out? And here.
Yeah, his OC1 condyles are pretty distracted there on the sagittal view.
Exactly. So exactly. And then so this is the condyle, that's C1, and that's a socket, and definitely there's a dislocation here. It's displaced. It should always, the condyle should sit on this socket normally. And when you see this, then you're suspecting, as Dr. Galgano said, Atlanto-occipital dissociation or a dislocation. So that definitely explains the patient's symptoms. And this is an MR. And what do we see here? We surely see total disruption of all the ligaments from front to back that hold up the neck to the upper cervical spine. You can see here with that STIR image, mid-sagittal one, the apical ligament, the anterior atlanto-occipital membrane, all the posterior tension band is gone. And you don't see any fractures with these injuries. It's a purely ligamentous injury, a distractive ligamentous injury, but definitely creating extreme instability to the cervical spine. Look, between the CAT scan and the MR, you can see the condyle C1 interval being enlarging and becoming definitely worse than even the CAT scan. So you have this patient that you've diagnosed this extremely unstable injury. It's a dislocation. What do you want to do next? Do you want to put this patient in traction to relocate him, or how do you want to treat them?
I think it's one of the.
Go ahead, Jonathan. Sorry.
Absolutely. Oh, sorry, Mike. I said this is probably one of the few absolute contraindications to cervical traction, and then the other one's like a complex hangman's fracture. But I'm wondering, in your maybe this is a good time to just maybe briefly go over it. But other than those, 2 or 3 real contraindications, have you really seen other pathologies or traumatic injuries of the cervical spine that you absolutely cannot put the person in traction?
Yes, I think, as you mentioned, the type 3 hangman's fracture, which is an unstable injury, that's a contraindication. AOD is a contraindication. Definitely someone with a complex skull fracture is a contraindication. Right. And the fourth one is an extension type injury in the setting of ankylosing spondylitis. Even if it's a little displaced, right, you don't want to put these patients in traction because it will just increase the fish mouth in the front and worsens the dislocation. So these are the 3 spinal and 1, the skull fracture 1, the fourth one. Yeah. These are the contraindications for traction. Otherwise, I usually, if there's a deformity, whether it's traumatic due to tumor or infection, I have a low threshold to utilizing traction and realigning the spine. So
how's this patient, another thing is, how's this patient secured for transfer to the MRI bed, if that makes sense? Like, I'm assuming you have the residents with them, like basically holding the head, maybe even duct taping the head down, whatever they need to do.
Yeah, 100% you're correct. So that was the only case of AOD. I've done maybe 6 AOD cases. That's the only case I got an MR on, because it's an extremely unstable injury. So because you can just diagnose it with a CAT scan. Now, absolutely, extreme spinal precautions are pursued. Nice and tight, the rigid collar bracing, and then extreme care with the transport. Now, even with that, that's not sometimes, that's still risky, and especially if someone doesn't have a deficit, because some of these people these days present because of the better pre-hospitalization, workup and care. Pre-hospital care has been improved significantly after an MVA. Some patients survive and they come in without a deficit because of the total spine precautions. So when they show up, I would put them in a crown halo vest, okay, to secure them as much as I can, especially because we're going to further treat them with stabilization. Makes the flipping process even safer. So absolutely. So very anxious about these patients in terms of maintaining their spinal precautions, especially if they're intact. So, but this is a nice MR demonstrating the total segmental disruption of all the ligaments of this craniovertebral junction, cruciate ligament, alar ligaments on both sides, and then the posterior tension band ligaments. So what's the treatment? Obviously, there's only one treatment for this injury, is the occipital fusion. And these are the different parameters that are used to diagnose it. Most of it is historical, because most of these parameters are either not sensitive enough or not specific enough, but let's go over them really quick. This is the BDI, Bayesian dense interval, more than 12 millimeters, then you have AOD. This is the BAI, Bayesian axial interval, from the Bayesian to the posterior axial line, more than 12 millimeters, you have AOD. That's the powers ratio, Bayesian to posterior arch of C1, over anterior arch of C1 to the opistheon. If the ratio is more than 1, then that's the diagnosis. Definitely it will miss AOD in the vertical axis, just the anterior or posterior, it will catch it, but otherwise it'll miss it. These are the X-Lees lines, or X lines of Lee. You draw a line from the Bayesian to here, opistheon to here, and if the dens or tip of the dens violates this line, or the posterior arch of C1 violates that line, then you have the diagnosis. And these are the more sensitive and specific parameters. That's the condyle C1 interval in the coronal plane, more than 2 millimeters, then you have the diagnosis. And that's the easiest one and the most sensitive, specific, has the highest predictive value, and negative predictive value is the modified condyle C1 interval. Simply you scroll to the parasagittal view, you look at the socket itself. If it's dislocated, that's its location. You gotta treat this patient as a highly unstable cervical spine case. So OC fusion, patient came back down the line neurologically intact. That was a great safe and salvage. He had an excellent outcome. So this is
I have a quick question for you, Nader, if you have a second. So what are your thoughts about these cases where somebody comes in and the CAT scan doesn't show a significant distraction of the OC1 joint, but you get an MRI scan and it shows that there's stir change in the apical alar ligaments, there's some stir change within the OC1 joint, but there's really no significant distraction. How do you treat those patients? Do you treat them with surgery, or are you going to treat them in a collar for several weeks?
A collar. So I've seen many of those, and if the interval or the there's no dislocation or dissociation on the bony imaging, the CT scan, and there's some stir in the joint, that means there's some injury to the joint, but maybe the capsular ligaments are not torn, so that's not as unstable as the one that I just saw. So so I would treat them, rigid collar bracing, mobilize them slowly, versus crown halo vest. But usually a rigid collar will do it, in my experience, and I've seen quite a few of those. So
Got
exactly.
it. Quick question from the audience, an excellent one. How for that OC construct, how did you select how distal, your LIV, and how in your experience, how short of a construct can you get away with in those kind of cases?
To me, O to C3. I usually do O to C3. I mean, adding, or you stop at C2, that's okay, but you know, going from C2 to C3 for me is not a big decision. Adding more points of fixation for this highly unstable injury, I'm more on the cautious side. You know, I mean, bone quality definitely plays a role, and anatomy, if you have like a high riding vert, and or like some people have a, for instance, say a vert that dissected, you have a dissection or an occlusion, and you don't want to risk really putting long screws or doing some extra dissection. So these are the things that I think about. Like if you have a vert dissection and you can't put a long screw in C2, I'll go to C3. But overall, you know, I rarely do O to C2. Usually I go to C3. That's my kind of stop. Lower intermittent vertebrae. There's no perfect science here, but it's just that's how I treat those patients. Like OC fusions, I never stop at C2. I always go to C3. So this is the second case, also trauma. 46-year-old woman, intoxicated, rollover car accident. She had a mild ulnar fracture. She had neck pain, shoulder pain, no real deficit. And that's the trauma activation, obviously, and that's the lateral film that the patient undergone. So she's still spinal precautions, and that's a lateral X-ray. If no one wants to comment, I can comment. Jonathan, what do you think?
Teardrop fracture at C5, a little bit of
exactly.
retropulsion of C5 posteriorly, and yeah, that's the main thing. I get an MRI.
So get an MRI. So would you put this patient in a rigid collar, send her home, have her come back in 2 weeks, or?
Yeah, sounds pretty good. I'm just kidding.
Yeah. No, so absolutely.
I would put her in rigid collar, get an MRI while she's there in hospital.
Exactly. So that's the CAT scan confirming what Dr. Rassouli has just alluded to. It's a teardrop fracture, burst fracture, highly unstable injury. You can see here all three columns are involved with the sagittal X-ray, CT scan, split fracture in the front here, and you can see the lamina is fractured. Definitely, when you get that MR, you see also the posterior tension band. So this fracture obviously qualifies as an unstable fracture. It's a teardrop fracture, unstable fracture. And she got a CTA or an MRA that didn't show a dissection. So how would you treat those usually? You know, we determine it's an unstable fracture. We want to treat it, stabilize it. So what's your approach in treating those? Anterior only, posterior, front, back? What do you guys think?
How much compression is there on the axial cut at that C5 segment? Not
really. Not, as you can see, there's CSF in the front and the back. You know, not that bad. I don't have an axial to show it, but that sagittal view shows definitely residual canal is about 80%.
You know, I think if there's no significant spinal cord compression, you could probably get away with doing something relatively straightforward from the back in this case. Obviously, if the fracture is comminuted and there's retropulsion, I would definitely advocate for a front back, do a corpectomy. I don't necessarily think that you need a corpectomy, at least based on the images I can see here. I might consider doing something, 2 to 3 above, 2 to 3 below in this situation from the back.
Absolutely. I mean, definitely that's a correct answer. And no one's going to argue against that. Posterior long segment fusion, multiple points of fixation. With those, you know, if there's always a burst fracture, to me, I like to reconstruct the anterior column just to offload the stress on the screws because those are shorter screws, and to improve, you know, or restore the lordosis. There's a little kyphosis, not that bad, but definitely for load sharing purposes, I like to reconstruct the anterior column doing corpectomy. But certainly, a posterior long segment is done too with excellent results based on retrospective studies. What would you do, Jonathan or Alex, or even Mike. Mike joined us.
Hey, Nadir. This is actually a really tough case because the patient's not that old and they've actually got a few degenerative changes above and below the already injured segment.
Yes.
And so, yeah, this is a hard decision-making case for me. I don't think it's a hard case to do either anterior or posterior, but I think to me it's a tough decision-making case. And I may be tempted to use Michael's idea here of going posterior, but try to kind of almost spare the facet capsule and maybe look at fusing short and instrumenting long and coming back and taking some of it out at a later date to try to restore some motion. But yeah, I need to have a look at all the cuts and work out exactly what to do. One of the other things I've done in a case like this is I've actually had a patient, that I lag screwed that fragment back together. So I actually got a screw across that split and managed to keep the body and just fuse a single segment. So that was good. So yeah, we'll lots of different options.
Yeah, absolutely. The most important thing with these injuries, it's just not to miss an unstable injury and treat it with a neck collar. I mean, that's the most important thing. The approach, back versus front back, you know, these are all correct thoughts and answers. For this one, I did a front back. If I go, this was an ancient case, so I did it a long time ago, you know, before I had more experience. I would certainly, if I'm going to do a front back in these situations, I would do it the front and then mirror it in the back. I wouldn't go long segment in the back. If I'm doing back only, I will go posterior long segment. But if I'm doing front back and for a burst fracture like this, I will just mirror it in the back. So for instance, this is 4 to 6. I'll mirror it 4 to 6 in the back. This was a touch of an overkill, but that's how I did it. And she followed up. She did okay. So let's go to another case. This is a 64-year-old woman who noted numbness in her hands for about 2 years, and then progressively started complaining of progressive numbness along her arms and then and toes as well. And she's been having gait instability, ataxia for the past 6 months. So slowly progressive neurological deficit in the upper and lower extremities. On exam, full strength. However, she had some sensory deficits. She had brisk reflexes in the uppers and lowers, and that's her MRI. Okay, Jonathan.
Nice case. So her exam is pretty classic of that rotating rotary paresis paralysis is typically found with a more commonly associated foramen magnum, ventral foramen magnum meningiomas, but it's all the same pathways anyway. So in this case, this is a dorsal. This is likely this is a intradural extramedullary lesion, most likely a meningioma. I mean, we have the long list of different things that this could possibly represent, but it does appear to be dural based. It's going posterior to the body of C2 and extends downward just slightly past the C2-3 disc space. And you see this spinal cord compression. There's maybe some evidence of spinal cord edema, and we can see on the axials, and it seems that the spinal cord is posterior displaced. So presumably, if you take this patient for surgery, it's going to be right in your face the whole time. So one thing to keep in consideration.
Excellent. As Dr. Rasul alluded to, first thing you see is spinal lesion like this. You want to put it in a compartment because this will dictate further differential diagnosis. So either it's extradural lesions usually are malignant, include metastasis and plasmacytoma. Also, they include primary bone tumors as well. Intradural extramedullary, it's usually a benign lesion, meningioma versus a nerve sheath tumor, which would be a neurofibroma or schwannoma, or an intramedullary lesion, which maybe gives you a different differential diagnosis, astrocytoma, ependymoma, hemangioblastoma, and so forth. So this is an intradural extramedullary lesion. And as Jonathan alluded to, differential meningioma, as you can see an arachnoid cleft here. If you see an arachnoid cleft, then you would think of a meningioma. as a differential, as a possible diagnosis. So, okay, so this lady comes in with this lesion, and certainly causing mass effect in spinal cord compression. You can see some cord signal change. How do you want to take this out? Do you want to do like a transoral odontotectomy to remove it, or how do you want to take this out?
I would, so with this type of a lesion, exactly. So your choice to really go anterior transodontoid. The problem, there are many, potentially even now one of the newer techniques is going endoscopically transnasal, and then going transpharyngeal and taking out the odontoid. But the problem with that, if you're going transoral, you're dealing with all the swallowing issues and all the dysphagia these patients have. Sorry about that. There's something going on outside my apartment. And then also you're working in a very deep, dark hole. I mean, the distance between where your hands are and the instruments, I mean, it is really deep, and your visualization is extremely poor. And you're coming anterior to this lesion, which may be stuck to everything down there. Personally, it's a mess. What I would prefer is to go posteriorly. I'd probably do a laminectomy at C2, possibly C3. Get everything nicely widely exposed, open the dura in a controlled manner, and do this widely, sever the dentate ligaments. Usually the spinal cord itself is pretty mobile once you do that. Just gently retract it away, and of course use neuromonitoring during this entire time. And usually, most of the time, you get a very, very good access to that meningioma ventrally. And I would use probably, in terms of my surgical adjuncts, I'd use the microscope, I'd use the ultrasonic aspirator, like Kuza, that I found that is very, very helpful to control bleeding during the case, as well as just being very, very careful with your, respecting your tissue planes and so on. And I'd probably fuse them C1 to, let's say, 1 up, 1, C1, 2, 3, something like that, C1 to 4, so whatever came easy. Probably 1 to 3.
Okay.
Why would you fuse, Jonathan? I'm just curious in the situation. I do know that there's some literature that shows that once you start taking down the multifidus and the paraspinal musculature at C2, that there's a higher rate of instability. But I've always been on the fence with these cases, whether or not to fuse it. The last few I've done, I'll be honest, similar to this, I've actually not fused and gotten away with it, but I used to fuse all of these.
100% agree with you, Mike. I think my concern would be if I got into the C1-2 joint. I think sometimes just with the exposure and really trying to get around that, make sure your laminectomy is totally complete, and even getting up about, you can even see it kind of gets like just to that posterior arch of C1 there. I'd be worried about violating that. If I got into that, I'd prefer to fuse. But I agree with you. I mean, I think you respect the facet joint capsules. I don't one level laminectomy. I agree.
Yeah, it's C1 too, because the joints are ventral. I do think it's relatively hard to get into it. So I think that's why at this level you could kind of get away without doing a fusion in these situations. Obviously, I'd get upward X-rays first, and make sure that their alignment is within appropriate parameters and whatnot. But my hunch is you could probably get away without a fusion in the situation. Once you take C2 down, you can actually get really, really wide there, and not have to really remove much of the facet.
Totally agree with both of you. So to me, intradural lesions, even if they're ventral, anterior to the spine, it's always dorsal approach. Like there's like if it's an intradural, you can get to the midline, always find a corridor. You can get to the midline easily, as opposed to an extradural lesion. There's more bony work with extradural lesions. Extradural lesions and ventral, then more bony work, more likelihood to fuse. Intradural lesions, less bony work, less likelihood to fuse, and always dorsal. So that's what I did. So just a C2 laminectomy, maybe partial C3, a little bit of a medial facetectomy. And you can see here, there's a dura tented here with these photoneural stitches. You can put a little stitch in the dentate ligament, as Jonathan alluded to. That's your C2 nerve. These days I would sack it. Before I wouldn't. And then you look at it, definitely I want to remove it en bloc. It's ventral to the cord. So Jonathan said, you use the CUSA, easy, take the tumor out, then stitch it back. And no instability, long-term outcome was good. And the pathology was a meningioma. Moving to the next case. And then, Jonathan, if you have cases, let me know. I have a bunch, but I'll keep going until you tell me.
keep going. I have one case, but no worries. Keep going.
Sounds good. All right, so this is a 70-year-old gentleman with developmental delay, mild mental retardation. He's baseline active. He lives in a facility, participated actually in the Special Olympics. He resides in a group home. He presented with a month difficulty of a month of progressive gait difficulty, loss of dexterity in his hands, had no fevers, no weight loss. His neurological exam, 5 out of 5 with the deltoid biceps triceps, 3 out of 5 with the intrinsic hand muscles, and then the sensations were normal. His brisk reflexes in the knees and elbows, positive Huffman's, positive Babinski. So this is his X-ray. It doesn't show much, and this is his CT scan. So what do you guys think? Alex?
Yes, hello. Great cases here showing. So this is obviously a destructive process. It looks like an infection, like a chronic infection, could be a tumor as well. And there's no history of trauma?
No trauma.
No trauma. This is a cervical thoracic region. The patient goes into kyphosis. I see some kind of ankylosing condition in the thoracic spine, but not in the cervical spine. And I wonder what is the blood sample telling us?
The blood sample, excellent question. I'll hold off. I'm going to show the images first because I'll give it away right away. Good for you. So this is actually a destructive process, T1, T2, and this is the MRI T2 sagittal view, and this is with contrast. Let's look at the contrast one. What do you guys think?
Is there a complete vertebral body missing when you count the?
So this is C7, this is T1,
Yeah.
and that's T2. So the disc is missing here, T1 and T2.
So there seems a lot of contrast anteriorly without any big, huge abscess. I don't see any contrast sparing, but the tissue goes from prevertebral through the spine into the canal, and the enhancement posterior to the cord could be reactive, could be two, and posteriorly between the spinal process, who seems to be intact, there's also a lot of contrast enhancement posteriorly. It looks, it's strange. I can't tell you from the MRI diagnosis.
So here are the labs.
Okay, can you just translate from American abbreviations into?
So his PPD was positive. They did a PPD test. It was positive. And this is the HIV negative, hepatitis panel negative, ESR and CRP mildly elevated. So this indicates what process?
Can you just translate PPD? This is not typical abbreviation here in Switzerland.
It's the test for if you've been exposed to TB.
Okay, so I see. Yeah.
I don't know what it stands for. I forgot.
Okay.
So
Thanks, yeah.
This is actually a case of Pott's disease, and usually with Pott's disease, you have this very large prevertebral phlegmon. It's really large, and it's always very destructive to the bone, like more than pyogenic. So that's we don't see much of these cases these days, but we still see some Pott's disease, TB of the spine. So how do you guys want to treat this? Michael.
Have you got any upright X-rays on the guy to see what his alignment looks like? Maybe some supine X-rays, see how flexible this is.
So that's the upright X-ray. Can't see much because of the shoulder, and you can see he's kyphotic, a little kyphotic.
Right.
And
Yeah,
you can see
that's
his line. That's how he lines up when he's supine, obviously, with the CAT scan.
Right. I mean, based on what I see here, I would probably advocate for doing this all posterior. I would do a posterior VCR, a T1 and T2, and then long segment fixation. I might try to put a cage in Because this is an infection case, I'd probably try to stay away from cement. For some of these tumor cases, I like to utilize like Kyphon cement. It gives a fairly large footprint. You don't have to muck around with the cage around the nerve roots. But in this situation, you could probably cut the T2 nerve root, T1 nerve root I would spare. That end plate's a little bit concerning there. I'm not sure if you'd be able to get a cage to sit on that, but I'd like to get some kind of strut in there, and then long segment fixation fusion from the back.
Mm-hmm.
Can you do this from the front? Possibly. It looks like that the manubrium is at the level of T3, so you might be your lucky day. Maybe you could sneak something in from the front and then fix them from the back as well. So that's a possibility as well.
Okay, great thoughts. What do you think? How would you do it, Jonathan?
Yeah, I agree with Mike. My preference would be to go all posterior for this. Just avoid. You're right. I mean, this is your lucky day. You could potentially go anteriorly because it looks like T1, 2 are just above the manubrium, but I prefer the control and the ability to get a long segment fusion, and even if you need to get ventral, go transpedicularly take down and do a VCR at T1, 2, you can probably get like an expandable titanium cage in there, something small, and just expand that out and just correct his kyphosis. And I agree with long segment. I'd probably go like 3 or 4 up, 4 down.
I just saw Matt because I'm not like being Matt Goodwin, man. Sorry, I just because I'm scrolling down to see who's with us just right now. So what do you think, Matt? How would you do it? Can you unmute? Let's see if I know. Aaron, can you unmute? I mean, I'm.
There we go.
Okay.
I think I would try. I mean, I think I would try to do front back. I mean, I'd have to look at that CT a little harder, look at what my axis is in the front. But if I could get in the front there and get a harm's cage in there, and then go in the back and back it up, I'd feel a lot better about everything.
Okay, great thoughts. The only thing for going to the back, yeah. Who wants to say something? Sorry.
I just we have a history of 1 month neurological deterioration, gait difficulty, but the infection, I guess it's month, maybe a year old, and I think the infection is, you can cure this infection with antibiotics, and you can help the patient from his gait difficulty, I guess, easier by going from posterior and avoiding to go through the infection from the front. These are my thoughts. We have had many visiting doctors from India in Switzerland, and they told us that they treat TB less aggressive than we would do it, and we do it in Switzerland because they rely more on the antibiotic, on the anti-infective therapy. I would love to see some recommendations in the chat box when there are people from countries where TB is quite more frequent than here in Switzerland. I have a good feeling if we go from posterior laminectomy and instrumentation that this could be enough, and the rest is done by the antibiotics, by the chemotherapy.
That's a great thought. I would probably do that these days, but back then I did more on the aggressive side. So we got an exposure. We exposed it, then the CT surgeon cut the manubrium for us so we can kind of see. Now the problem is I like to start from normal to abnormal. There's no normal to start from, so that was easy. You got to dig into that stuff that's really stuck and very fibrous. And then we did a front back. Definitely put the patient in a little traction to help keep that alignment, and then use an expandable cage for that. He did ultimately well.
Why not go all posterior? I'm just wondering.
So
if you were going to use
for a cage, the problem is like we took 7, T1 and T2. Can't sacrifice the C8 nerve root. Can't sacrifice the T1 nerve root. That's the only thing. Otherwise, you get it exposed. You look at those nerves. It's very hard to sneak in a cage. Like to me, like a posterior corpectomy, it's got T2 and lower. Anything T1, C7, all from the front. This one involved T1, T2 for sure. The end plates of C7 were not that good. Let's go here. See a little bit involved. So that all had to go. And just the C8 and T1 nerve roots, you can't sacrifice them to percage going from the back. Now, I agree with the thought like, okay, decompression and fusion from the back, sure, he has good bone quality, and you decompress, stabilize, improve the alignment a little bit, and then hope for the chemotherapy antibiotics to help with the infection, which they will, and reconstitute the bone. Probably the bone will reconstitute here a little bit. Okay, let's see.
So real quick. So you said, sorry if I missed it. You said now you would do that. You would not do that in the front. Am I getting that correct?
Yeah, I mean, in an emergency situation, I think, especially if it's an infection, right? Like I would posterior lung segment, restore the alignment, much faster surgery, less morbidity. Patient did well. That other patient did well ultimately. And, you spare him an exposure in the front and dysphagia and what have you, for sure. Especially now that, you look at the literature, and I agree with Alex, like you stabilize, decompress, you don't have to be as aggressive as we historically were, especially with these infections. But
I didn't see it all. It just looked like there was really poor bone there, but
this bone is
no. At the if you were to not do anything at the that CT of the
right, yeah. I mean, there's not too
Yeah.
much anterior column, but you're depending on the rib cage, you're not going to get perfect correction. He's going to be a little kyphotic without anterior column reconstruction. The other thing with the posterior decompression, you're weakening it even more. Like, right, you're weakening it more. You're adding hardware, but you're weakening that segment more without reconstructing the anterior column. That probably is the downside. I wouldn't take the facets off. I will probably just do a laminectomy if I just go posterior only. I don't want to weaken it further than it needs to be weakened if I'm not putting a cage.
Nada, may I have a question? Intraoperative, when you went from the back, there was contrast on the MRI. Did you find absolute normal anatomy from the posterior, or have you?
I did not. No laminectomy.
No, did you find normal anatomy? Sorry, anatomy. The bony structures from posterior, because on the MRI there was contrast.
Normal, yeah. It didn't look. Yeah, it didn't look too bad as far as I recall. This was done a long time ago. Okay, so this is a 65-year-old female, history of breast cancer, diagnosed 3 years ago, status post-mastectomy chemotherapy, admitted with severe neck pain. Immobilize the patient, has extreme neck pain, have her lay down, pain improves. Neurologically normal, pretty functional lady. Matt, what do you think? And then Michael. I'm not gonna. You guys can participate without me asking, but let's start with Matt. He's the
bad. Does she have known disease, metastatic disease, other places?
Yeah, she's obviously. I mean, you call the oncologist. They tell you prognosis at least 2 years.
Yeah. She's on treatment right now.
Treatment? Not really. It was diagnosed 3 years ago, and then she's comes in with she's not with neck pain, and they say there's a lot of room to start all sorts of stuff.
Yeah, it's hard. I mean, obviously, I'd get the rest of the workup we need in terms of playing films and having her stand and seeing what things look like. Get an MRI.
So that's the MR. We can go back to this. So
can we see that MR again, or you want to stay here for a second?
Sure.
Yeah, so I guess the question is well, there's a lot of questions, but a big one's going to be what needs to be done, if anything, in the front there. Certainly, I think she's intractable pain with that sort of collapse. I think she's going to benefit from a surgery.
Okay, totally agree. So she's definitely, prognosis is acceptable. She doesn't have a deficit. Her pain is due to the instability, and this is This is a deformity because of that C2 pathologic fracture. So what she has, first of all, the diagnosis, diffuse spinal metastasis, and the index level is this one. She has a pathologic fracture of C2 and subluxation of C1 over C2. So
I think you could entertain putting her in traction before surgery as long as OC1 looks okay. There's no significant distraction there. Maybe put her in crown halo, try to get her reduced, take her to the OR and take her maybe C1 down to 4 or 5 or something like that, wherever you have some relatively decent bone stock. I think once you realign her, though, I do think her canal is going to open up and it won't look this bad on CT.
You would not use her. You wouldn't use her occiput. You go C1.
As long as C1 looks okay. I mean, based on this, it looks okay. But if the lateral masses are kind of ratty, then I would probably go up to the occiput without a doubt. OC1 in this image is shown here on the left shows a little bit distracted. I'm not sure if that's just artifactual or not.
Artifactual is just the parasite.
Yeah, I mean, if I have any concerns about my fixation at C1, I wouldn't hesitate going up to the occiput at all. Obviously, it's a metastatic case, so if you could spare her, going up to the occiput just for quality of life purposes, I would probably try to do that. I would definitely avoid going anterior in someone like this, though, if at all possible.
Yeah, I guess I would go to the occiput pretty quickly, just thinking that I don't trust the tumor bone. I know I have bone in the occiput I could use and be pulling on it a little bit. Yeah.
Okay.
Yeah,
great.
if I did stop at C1, I would probably use something like sublaminar bands as well, just another adjunct, just to give a little additional fixation. But I agree with you, Mike. I'm sorry, Matt, that I wouldn't hesitate to go up to the occiput if C1 looked ratty and I didn't have good fixation.
Okay, Jonathan, what do you think? And Alex, you agree with the treatment plan?
Absolutely.
Yeah, I agree with what Matt. I just echo what Matt and Mike said. I would have very, very short. I would be very, very keen on going to occiput here. Like I wouldn't really hesitate on that. If I would prefer to do C1 just again from quality of life standpoint, but these patients are usually just so grateful to be out of the pain, that pain that due to the instability that they don't even really. I found that they don't really even care. So yeah, I would be inclined to do like occiput to like just like you said, just wherever you get like good purchase, go down numerous levels because her bone quality looks horrendous. You see, she has innumerable mets everywhere. It's probably mush.
Yeah, that's the next question. Is kind of looking just through these cuts too. You can see it's not going to be awesome.
Yeah,
figuring out where to stop and
they're getting iliac crests, things like that. Not that I don't even know how to help you, but
Okay, great thought. So I agree. I mean, we talked about cervical traction and the contraindications. Certainly, this is not a contraindication. Low threshold. If there's a degenerative deformity or a deformity due to a tumor or a fracture, then I would have a low threshold to achieve realignment with traction. I'm a huge traction proponent. I use it all the time. Short, threshold to doing that, except obviously for contraindications. We mentioned them a while ago. So here we put this patient in crown halo traction, just about 15 pounds. As you can see now, locked her in a halo. You can see it realigned. When you realign, you decompress the spine. And now you can lock her in. So you can see that because of the instability, it's a little distracted and realigned near perfectly. And then you stabilize it with an OC fusion. I had an intra-op picture. I don't know where it disappeared. And that's her CT scan after 2 years. Okay, she did not fuse at the occipital-cervical junction as we expected, but her bone reconstituted with treatment and bone health, and she had a great outcome. Obviously, this a few years ago, she succumbed to her cancer, but definitely she lived 3 years after the operation.
Are you putting C1 screws in a construct like that if you go up to occiput, or are you just going to skip them?
I skip it. I just let's just points of fixation. I skip C1 faster, less blood bleeding, and you can certainly include it, and I always use these days those hinged rods so that I won't contour them. So that's in your way of instrumenting C1. And then because I also want to put bone graft as much as I can in that gap, I skip it, but certainly you can include it, either or, but I would definitely low threshold to go to the occiput. It's highly unstable. Bone quality is not good, so you want to get good fixation, multiple points of fixation above with the occiput and then below with those screws, C2 and then the subaxial screws.
And then did you skip 4 because the bone was bad, or
The
'cause you're
bone was
putting
bad, but
Yeah,
nothing would
okay.
hold. Yeah. It's like you put it, it's mush. So that's why I skipped it. I tried, but it did, I drilled and tapped, it just didn't hold. And you should I keep going, or you want to showcases, Jonathan? Whatever you want.
Sure, I can do a case.
Sounds good.
Give you a little break, Nader.
Those are great cases.
Yeah,
Oh,
those are fantastic cases.
Stop sharing.
Okay. Let's see. Oops, sorry about that. Okay. Can you all see my screen?
Yes, sir. And I'm
Okay,
gonna
great.
look at the chat box. No one else take a peek here.
Okay. So this is a patient. I actually got during my fellowship. I thought it was a pretty nice case because it illustrated a couple of things I often think about when I see these patients. So it's a 42-year-old lady who was intoxicated. She was pedestrian struck in the middle of the winter, one of the worst blizzards we had out here in Cleveland. So I mean, like the roads were just a mess. And this was, of course, happens at the best time of the day, aka midnight, Saturday morning. So Saturday at midnight. So and of course I'm on call. It's winter, it's snowing, it's a big holiday, it's midnight. It's just, it's a fantastic time for this to happen. So this patient was unfortunately a frequent flyer at this hospital, had one of those charts that when you open them up, it's like 10,000 admissions and ER visits and things like that. And she had a history of IV drug use. You can see it all there. She was a smoker, Hep C, IV drug use, and she had pretty significant axial neck pain. Even though she was intoxicated, she was, complaining of pretty significant axial neck pain. She was noted to have weakness in her hand grip, but was otherwise neurologically intact. So you can see we didn't get a X-ray at the time. However, you can see that she subsequently got this is a scout on the CT. You can see that she has this process. I'm saying process because I'll tell you why. Process going on C3-4 with kyphosis above it. And then I just put a corona here just to show you what it's looked like. This was read as being an acute acute traumatic fracture subluxation at C3-4. I'm just wondering what you all think about that. This is an acute trauma.
Yeah, I don't think that looks acute. It looks like it's sclerotic. I suspect probably has some element of burnt out osteo and discitis and just happened to get hit by a truck. Those
I agree with Michael on this one. Plus, she has all the risk factors for like an infectious process, and the discs is disrupted, the implants are disrupted, so speaks for like for an infectious process or a burned infectious process.
Yeah, totally agree. That was exactly my thinking as well too. I think just the trauma was a little bit of a red herring. Just a patient who had this kind of going on in the background, and due to unfortunately her extensive psychosocial issues, never really sought adequate medical care, and in this accident led her to subsequently get cervical imaging, wherein we made the diagnosis. So we felt that this was more of a subacute process. So we decided to, and given her exam, we decided to hold off on taking her immediately to the OR and wait for her to basically get a better exam and take her in the morning with a spine team that can handle the. I don't think would anybody argue about potentially taking this patient for surgery? Let me ask you that. We got the MRI overnight.
Like emergently?
Let's just say surgery. Well, okay, let's ask that. So surgery versus no surgery, emergently versus not emergent. Emergent being taking her right away after this MRI?
To me, surgery, yes, not emergency.
Agreed.
Yep. So, oh, yeah, sorry. I didn't want to show what we did. Okay, so what would you guys do? So I think we all are pretty much unanimous that this patient needs surgery in a non-emergent manner.
Exactly what you did. PCR, and then probably 2 to 5 or 2 to 6 from the back.
I would do the same, Jonathan. Honestly, if you didn't show the images, I would have done the same. I mean, I would go front back on this one. To this is a nice case. I would go front back.
Would anyone go all posterior, Eddie Cassie?
I would not, but I think you could potentially get away with it, though.
Right. And the argument being that you want anterior column support, source control, these kind of things, or?
Right. Yeah, exactly. And plus, you're going to get much better restoration of alignment from the front, too. I don't know how much you're going to realign her from the back there. I would get her to the OR, put her in about 10 or 15 pounds of traction. You'd get a perfect alignment after going from the front and back.
What would be your choice of cage? Anterior titanium?
I usually use an expandable cage for these. I use the titanium expandable. I don't think it's unreasonable to use a Harms cage. That's probably the best, right, as far as getting a true arthrodesis. Or you could potentially use a fibular strut, which I've used very infrequently.
Mm-hmm.
On the chat box, guys, we've got a comment. Sorry, guys, on the chat box, we've got a comment from Nikale, I think, that can you get away with anterior only here?
Yeah.
I don't know what you guys think of that. I think it's worth discussing because some would advocate for that.
Yeah.
It certainly is a possibility. With it, with my personal preference with a patient who's getting a 2-level high cervical corpectomy, and especially with this, I hate to say, with this type of a patient who is likely going to have very poor follow-up, I would, this is a patient that you operate as soon as they get discharged. You probably will never see them again unless there's some sort of a major problem. So I would prefer to back up a 2-level corpectomy with if I'm not going to consider using ultra low dose BMP, I would prefer backing this up posteriorly.
Yeah, Jonathan, I completely agree with you for this case. I think, in a patient who's completely compliant, who's been unlucky enough to get an infection in their neck like this, you may be able to spare the posterior if you get great fixation at the front. But for this type of patient, you get one good shot at it, as you're suggesting. And so I agree with front back.
Yeah, and I agree with front back too. To me, 1-level corpectomy, sure. But when it's 2-level corpectomy, I would go front back. Plus, this is kind of a deformity case too, right? Like it's kind of a kyphotic deformity. So for that reason too, I would go front back, like a fixed kyphotic deformity. Plus, when you go from the back, you don't have to do a laminectomy. You just stabilize it because all the, when you decompress it from the front, it's going to be adequate. Restore alignment, and decompression from the front would obviate any decompression from the back. So you just back it up with, and you're mirroring it. You're not adding, you're not losing more motion segments when you back it from the back, right? Like you're doing corpectomy of C3 and C4, then the plate from C2 to C5, and then you mirror it in the back. So you're not losing more motion segments by backing it up. It just makes it better.
Yeah.
You're not stiffening this segment more.
Would you consider not using a plate for this if you're going to go posterior?
The only time I don't use a plate, like this is like, it's like the plate improves the deformity, right? Like it improves the lordosis. I think the plate is key in those situations when you have a deformity. If it's degen, for instance, and you have a 4-level ACDF, I'll do standalones in the front and then back it up in the back. If it's a non-deformity case. This is a deformity case secondary to an old infection.
Yeah, totally agree. So this is exactly what we did. We did this all. We did this all in one shot. We did not stage it. We just flipped the patient over and we anterior first and flipped the patient to posterior. Culture came back as MRSA. She'd have pretty significant dysphagia postoperatively. Had to get an NG tube, and you can imagine in this patient, it was constantly pulling it out and getting calls from the nurses all day. I probably had to be replaced about 50 times. You know, it just to add to the challenge of managing this very challenging patient. But eventually, she did okay. It got better, and she was tolerating PO solids, and she was eventually discharged. And you know, as is the case with most of these patients, we don't usually see them. So some of the questions that I came up with just thinking about this case overall. You know, we really discussed medical management or surgery. I think we all decided that we would, you know, potentially anterior alone or anterior and combine anterior posterior. It's interesting because when I discussed this with some of my colleagues over here at Cleveland Clinic, it was interesting. It was split on front back, and a good portion of the surgeons would do posterior only. It's interesting that now nobody here wants to do posterior only. So it is interesting, very, very interesting. The choice of interbody, you know, titanium versus iliac crest versus fibular allograft or PEEK potentially. I think, you know, we all would use titanium, even though in setting of infection, there are some properties of titanium that can prevent a biofilm from forming around it, even though it's very weak evidence against that. But certainly putting cadaveric allograft would potentially be better than putting cadaveric allograft. Just wondering about what your choice of screw would be at C2. We decided to what I guess Jefferson calls a parsicle screw, which is a screw that traverses both the pars and the pedicle of C2, rather than traditional just C2 pedicle screw. But I'm just wondering what's your preference here for at C2?
I do pars screws, but this is a better screw. I mean, this is a kind of closer to a pedicle screw than a pars screw, obviously. Long and just, you know, it looks, I just do a pars screw. But definitely a pedicle screw is superior than a pars screw because it's a longer screw, for sure.
Jonathan, I like your construct here. I think it's really good. And yeah, the C2 pedicle screw, if you use navigation, is just a walk in the park for these. You know, most patients you can navigate a C2 pedicle screw into. I used to be a lot more anxious doing them freehand, but now it's pretty straightforward. And look, I think when you look at your construct there, I really like the way at the distal level, you guys haven't dissected out that lower facet. You've gone for a flatter lower lateral mass screw. The only other thing sometimes I've done in these situations when I've had the navigation, and you know, not that cost should be a major concern, but your lower screw, if you've got good support at the front, sometimes I do a transarticular screw. So actually go across the facet. It's almost a reverse lateral mass trajectory, and it saves you an implant point, and it really keeps you well off that facet at the bottom as well. It's really easy to do under nav.
Jonathan, someone had mentioned in the chat box about using an integrated strut with a screw system. I know there are some industry vendors that have those out there, and the thought was that maybe this could have avoided dysphagia. My personal thoughts are that I don't think it's a plate that causes dysphagia. It's usually the you know, the exposure and having to go up to C2-3 and really tug the hell out of the esophagus. So I don't think it's the plate at all.
Yeah, I agree. It's just something I thought about in retrospect, you know, because we debated putting a plate on her during the case, you know, specifically for this reason.
Yeah. I don't think the plate.
I'm sorry.
Sorry, Jonathan, keep going.
I was gonna say the attending I work with did not want to put a plate. I wanted to put a plate, and then when the patient got dysphagia, I got blamed for it. So
I don't think the plate causes dysphagia. I think if you're going to put the plate should have dysphagia, it's the exposure and the traction on the esophagus and the upper and the at C2. I mean, there's definitely. I mean, look at this plate. It's flush. You can't put it more flush than it is. It's the exposure for sure that causes the dysphagia, and you know, it resolves, gets better, and goes away.
Curious about not in this case, but any thoughts, or do you and any of you routinely or possibly use ultra-low-dose BMP for cervical corpectomies?
I never use BMP in the anterior cervical spine, and almost never in the posterior cervical spine, unless like it's a revision and failure. Yeah, but in the anterior cervical spine, just if there's an issue, it's hard to justify. I mean, it's just like some people have used it low dose with success in places that use it routinely, but I've never used, not a single time, BMP in the anterior cervical spine.
Yeah, I don't think we ever use it in the anterior spine. I'll certainly use it posteriorly.
Yeah.
Yeah, the comments about the plate. I mean, I'll sometimes cut the harms cage so there's little, little tabs, and you can put a screw through the top and the bottom to hold it if you're going to go back it up. But I agree. I don't think it's. I mean, that plate's so flat and so flush. I don't think the plate's the issue. I mean, I think that looks great.
What about for what is your use and thoughts about using steroids for elective ACDFs, or not for this case, but let's just say for elective anterior cases, either IV or topical? What are your thoughts on that?
Jonathan, I think there's a recent randomized trial on exactly that issue that showed, and I can find the reference and put it on Twitter later, but I think it showed a significant benefit to IV dexamethasone for about 24 hours after surgery, so intra-op and then a few doses post-op, and with no increased infection or non-union rate. So I'm very happy to give it. Perhaps in this infection setting, I wouldn't do the post-operative one, but certainly intraoperative, part of our anesthetic protocols for a lot of things. So,
yeah, me too. I give it just IV dexamethasone intraoperatively for many reasons, for the nausea and also for the dysphagia. But there's, as Mike has alluded to, there's like not only one, a few level 1 or randomized, we can say probably randomized trials showing that IV dexamethasone works, and also even better, topical. I think it may be a triamcinolone. I can't remember the topical agent, or but it works even better to prevent dysphagia. Pretty compelling evidence. One of those trials were done at Northwestern by our orthopedics colleagues.
So you give it for every, what do you give it for? Every ACDF, every?
So the anesthesiologist, I don't really ask for it. Like, are you okay with dexamethasone, for instance, 6 milligrams? I say, yeah, that sounds good. They usually want to give it for nausea. But I think it helps also for dysphagia, since there's evidence that it does not really cause any issues with pseudoarthrosis or anything like that. But yeah, I almost give it every single case, 1 dose.
Yeah, same here. I know exactly the paper you're talking about, Mike. I'm forgetting off the top of my head, but yeah, I believe it was 1 dose intraop and 2 doses post-op, and they had significant decrease in the rate of this post-operative dysphagia without any sort of concomitant increase in the rate of pseudoarthrosis. So it seems like at least giving it intravenously is pretty good. Topical, I think, works even better, but there is, I believe, a few case reports of esophageal erosion with that. With the hardware, so that is potentially a risk of using that. I don't know if the causality is there, but it has occurred anecdotally with enough frequency where I think there might be some relation there. So just very quickly, a couple of things. Do we have enough time? I don't have. Oh no, we're way past. Okay,
we're way past. Okay.
Yeah, maybe we'll save this for another time.
That's awesome that all our participants remained with us. That's great, and always good to see you guys. And hi to Miss Galgano. Good. All right, guys. So whose turn is it next?
Yeah. So next week it'll be myself and Dr. Tim Moore from Metro Health. He's going to be presenting about cervical spine trauma. He's actually the attendee I work with for the case I just presented. So it'll be interesting to have him back, have him talk about that. So I look forward to seeing everybody next week, and we'll have a very, very nice session together.
Have a good evening or good morning, everybody. See you.
Take care.